One shot. A whole year on Zoom, I was talking to you in the state of being muted. Oh, that is so funny. Can you all hear me? Can you all hear me? Type in the chat. You can.
Yes, we have
Yay! So you get to hear me again. Okay, I will. These things happen all this well. It's a good thing we do have the chat, or I could have gone on and on. Okay, we are now live. Isn't that great? Okay, I will begin again. That was rehearsal, I think. Okay, so we're going to talk about the state of chronic disease and vaccines among African Americans. So I was providing an introduction to you. These are the top 3 causes of death among African Americans, and we can say Black Americans for the sake of this presentation. According to the Centers for Disease Control and Prevention, our top 3 are heart disease, cancer, and COVID-19. Now, when we look at the life expectancy among Black Americans at this time, our life expectancy has actually increased. We're living a lot longer. But the problem is when we look at these causes of death, we are looking at many people ages 18 through 49 who are dying at much earlier ages, which is a great cause of concern. So let's define chronic disease. Chronic disease is any illness that persists for at least a year that requires consistent medical attention. So you can imagine for diseases such as breast cancer, when people may be in remission or out of remission, these are disease states that require a lot of consistent care. So let's start with heart disease. When we look at heart disease, we know a lot of the risk factors consist of diabetes, obesity, and even hereditary causes such as genetics. So when we look at heart disease, we're considering there's a sclerosis, usually a hardening of arteries that's caused by some of these other factors, which can cause a sudden heart attack for anyone of any age. The second leading cause of death that we have here on the screen would be cancer. And so among Black women, the leading cause of death by cancer is breast cancer. And for our Black men, the leading cause would be prostate cancer. And again, all of these different chronic diseases are issues or areas for prevention when we're looking at the state of Black health. And last but not least, COVID-19, we know that that is our current ongoing pandemic. We know that our Black communities have been ravaged by the COVID-19 pandemic for a variety of reasons. And we'll get into that a little more today. Because whenever I discuss health disparities or health inequities, it is the state of Black health is not about just discussing the numbers. It's about discussing the root causes and also the potential solutions. What I was saying while I had muted myself was that you all, I'm going to ask you some questions today during the presentation. So feel free to unmute yourself or to type in the chat now that I can see the chat so we can participate in this discussion on the state of Black health. Okay, so speaking of COVID-19, I would have been remiss not to have the most current statistics available for you on our cases, hospitalizations, and deaths. This particular graph that is from the Centers for Disease Control and Prevention shows you these cases, and it has a X beside the number. And so what we're looking at here is what times or more of a risk ratio of how much more likely certain racial ethnic groups are to have COVID-19 compared to some of the other groups. Now, please keep in mind, in this particular case, the white community is being used as the referent group. You will see in some other studies, and even as we extend our discussion, that we can also use other referent groups when we're having these discussions about health disparities. In this case, if you were to look at the screen, Black or African Americans are second in line, if you look at the rankings, in terms of cases, hospitalizations, and deaths from COVID-19. Can anyone out there tell me why they think that might be at this current time? Please unmute or type into the chat and I will read. Why do you think the cases, hospitalizations, and deaths are still secondly ranked higher compared to some of the other ethnic groups that are shown here? Anybody? Anyone in our live or Zoom audience?
Access to care.
I hear access to care here from our live audience. Yes, so absolutely, access to care is one issue. And access to care can relate to, well, we'll go into that a little bit later, but access to care relates to a lot of things, such as, can I actually get to the place where I need care for COVID? And access, are there any barriers set up for me once I get to that place for care? So those are some definite items that we had. Anything else before I share what I have?
Chat.
Fear or lack of trust. Yeah, we're going to talk a little bit about medical mistrust. And when we talk about that, we're going to talk about some myths around that as well when it comes to the Black community. Access to care. We do have a slightly lower vaccination rate at this time. We'll talk about that in a few minutes. Yes, so all of these different things. So a few things I have for you, and also some other notes from the Centers for Disease Control and Prevention. Some of the factors that are included when we look at these numbers and cases, especially, some of these have to do with living conditions. And what I mean by that is, for some Black or African Americans, not all of us, but for some that may be living in different housing situations, there could be issues of poor ventilation in the housing. There can be issues, not issues, but a culture of multi-generational families where people may be living close together. When I was in Memphis for a time during the pandemic, one of the across the street neighbors, there were actually 3 generations of people living in the home at the time. So that's a good example. Now, they did remain COVID-free, which was wonderful, but that's an example for you of that. Some other things to consider when we look at these cases: many people within the Black and African American community, we are considered frontline or essential workers. Meaning, if you think about it, after the country opened back up, after March or April of 2020, many of the restaurants opened back up, the hospitals were always open. And in some parts of our country, these were areas where there were a lot more people of color having to go back to work prior to the vaccine. And even now with the vaccine, people will have a lot more exposure because of the types of employment that they have. So those are 2 of the factors. The third factor, which was alluded to by access of care, is obviously longstanding discrimination and bias that occurs within healthcare that is well documented when it comes to Black people of all different socioeconomic statuses attempting to receive quality health care. So these are some stats that I wanted to share with you, and I wanted us to discuss underlying conditions. Thank you, Jamie, and also other medical issues, which exactly is why we're talking about chronic disease today and vaccines, because the underlying health medical issues that some of us have at larger numbers does put us at risk for COVID-19. I did not want to go through this presentation and not honor my own family. The man on the left is my dad with the striped shirt on. And the person on the right who looks like he's explaining something is my brother-in-law, the other Dr. Story. This is my husband's brother. And so we were all at the same location at one time. The woman on the right is my husband's Aunt Brenda. So many of us, all of us, no matter what our race or ethnicity, have been impacted by COVID-19. When we talk about the disproportionate burden, within a month, I personally had at least 9 family members in the hospital with COVID-19. I think 6 of them were in the hospital at the same time. One of those people was my dad, who I ended up caring for, who recovered well. He's doing very well now, and we're very grateful for that. Unfortunately, my husband's Aunt Brenda succumbed to COVID-19. She did have some underlying health issues, and she passed away in July of 2020. So I wanted to honor them and talk about COVID as not just a number, but as faces and people who we love and who we know, and the things that we are still dealing with and grappling with. So what are some sources of medical mistrust? Tuskegee is often quoted as the, I'm gonna say the monster of medical mistrust. And when we look at the state of Black health, when we consider our current pandemic, when we consider chronic disease, we have to go back and think about access to care. We do have to go back and think about what are some of the historic sources of medical mistrust. And as identified in your series, what are some potential causes of intergenerational trauma? So you all may know this, but the smallpox vaccine was actually initially tested on slaves. This is according to the foundational text, Medical Apartheid by Washington. One thing I want to highlight for you though, since it is Black History Month, it's a recent discovery for me. Essentially, vaccines were not necessarily discovered in the way that we think that they were. There was a slave named Onesimus, and I believe I'm pronouncing his name correctly, who was approached by a slave owner named Gather, who was also some type of pastor. And this slave was approached because he had a scar on his arm when he was brought over from Africa. And so the discussion with this slave was, how did you get that scar on your arm? Well, as it turns out, some of the slaves had been inoculated before they even came here. Part of some of the historic medicine was that if someone was sick with a certain disease, the pus of that person would be the well person would be cut, and then the pus of the infected person would be put inside of the wound of the other person. This slave, Onesimus, had a scar. He shared with Gather, the slave owner, what had happened to the best of his recollection. He was a very intelligent man. Gather used that information to begin working on the vaccine. And as we know, Dr. Jenner has received credit for the modern day vaccine when we look at smallpox. But the root of this actually was with an intelligent slave who shared a conversation. So I want to share that on behalf of Black History Month. Now, where does the trauma come in? Obviously, the slaves in general, and obviously under Dr. Jenner, they did not have a choice to sign up for IRB, to sign a disclosure. They were forced to have these vaccines and these trials. So that's a very historic sense. The next thing I do want to mention is the Tuskegee experiment. Hopefully most of you all are familiar with it. What happened in reality in this experiment is different from the myth that remains persistent in our Black communities. What actually happened is the United States Public Health Service was commissioned and allowed to study syphilis in Black men. At that time, many Black men in certain areas had syphilis, and these researchers and doctors wanted to understand and trace what was happening. They offered incentives to the men, such as burial plots, although they were doing spinal taps and other methods on these men. During that time period, which was a very long time period that this study occurred, penicillin did become available to treat syphilis. The tragedy of these experiments, or the Tuskegee study, is that this was not offered to these Black men. So obviously many of them died and could have been treated. The true root of medical mistrust when it comes to intergenerational trauma with this issue is that many people in the Black communities, many people, including one of my aunts when I mentioned Tuskegee, believe that syphilis was given to these men, and that was not true. But this myth perpetuates, particularly among older generations, and continues to fuel some medical mistrust, again, among some of our older Black communities. More recent sources of medical mistrust include patient-provider communication. And I'm going to show you all a video, if you give me a moment. Hopefully this will work. If not, we will just go back. When we talk about discrimination in medical care, I want to share with you a very tragic and recent story of a medical doctor in Indiana who contracted COVID-19 early in the pandemic. She went to the hospital to be treated. She was very well knowledgeable because she was a physician of different types of care. And according to her testimony and her live video within the hospital, and she died not too long after, she was not treated fairly or appropriately. So let's listen in and then talk a little about the literature around this. And we have a commercial, sorry. Someone just told me they're not able to hear the video. There's a share audio on Zoom. If you all would give me just a minute, I'm gonna attempt to. Okay, I'm going to start the video again. You all just chat me if you're able to hear.
This is the second worst day here at IU North.
Yes, we're good.
Yesterday, a doctor wanted to send me home. You know, at that time, I'd only received 2 treatments of the remdesivir. He said, you don't need it. You're not even short of breath. I said, yes, I am. Then he went on to say, you don't qualify. I must have, because I've gotten 2 treatments. And then he further stated, you should just go home right now. And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. I was crushed. He made me feel like I was a drug addict. And he knew I was a physician. I don't take narcotics.
I have to pause there because that is so painful and it's so real. It's the gravity of what is happening in our communities. And you can imagine, this is a medical doctor. So imagine what happens to members of the Black community when they are under medical care and they don't have the knowledge, they don't have the words or the ways to attempt to even communicate with their physicians clinically. I'm going to take a pause here and ask for any responses or reactions in the chat or verbally from our live audience or our Zoom audience. Okay. So I'm going to move forward and the chat is open to you at any time. So I thought this was one of the best illustrations of what we see in the research around patient-provider communication. We know, according to a lot of the research, Black patients express, as she mentioned about the doctor, a sense of disrespect when they go to the doctor and ask questions. Sometimes they report the tone of the physician is disrespectful. Sometimes they report, and we know from studies that oftentimes Black patients are not offered the same introduction to novel and clinical trials as other patients, as exemplified in the clip when she mentioned Resavir. Yes, we have a comment from the live audience. Thank you.
I would also like to add that this is some prime example of how African Americans are perceived as experiencing pain differently. This
Yes.
has been a stereotype
Yes.
in the literature for
Yes.
a long time, and that our pain isn't properly managed
Yes.
because there's a preconceived notion, which is very discriminatory, that we are drugs.
Yes.
So, I wanted to add that because one of the things that she said is, I'm in severe pain. My neck is hurting. And,
Yes.
for whatever reason, the doctor response was, I'm not comfortable giving you more narcotics. It's not a matter of your comfort, it's what's clinically indicated.
Yes.
So I think that was very racist.
Yes, it was absolutely racist. And thank you for bringing that comment up within her commentary, because we've heard, even though it's a little different topic, we've heard very similar reports in terms of pain around childbirth and outcomes among Black women. And so it's very important for us to highlight that. Thank you so much, Dr. McKeltry. So we see all these things, the discrimination and all of those points within the perception of pain, and also the general discrimination of, can you imagine her being a physician lying there, knowing what is best for her and not being able to receive the care that she more than likely would have received had she been somebody else. So all of these things in patient-provider communication we see within the literature. And Vicki, yes, I am sick of it as well and heartbroken that we have providers who still practice this unacceptable ideology. Yes, indeed, we are. And so the other thing that I want to mention around that, again, I think I mentioned about Resavir, new medical treatments. So she knew this was available, and yet it was not accessible to her when it could have saved her life. And so this highlights the reality and the literature of what is going on and why we need to dismantle this systematic racism around medical care and treatment during this time. The next thing that is happening in terms of recent medical mistrust, when we look at younger generations as well, we can talk about a general mistrust of government. And in one of the latest studies around the flu vaccine, one of the things that younger people mentioned in a qualitative study, and was also mentioned in my dissertation study, even though it was older, that many people perceive death and disability around getting vaccines. Well, if you go back to history, and you go back to what just happened in the video, you can understand a medical mistrust of government and also hospitals and other places. I want to ask you all, especially maybe some of the people who are students on here, what do you think are some of the more recent sources of medical mistrust when it comes to vaccines and even medical care? You can just type in the chat for me. This is your time. or anyone from the live audience? Okay. Or any other comments about the video, and we'll go on. So, and I'm still really sad about that doctor and all the perceptions that went into that. You'll notice at the bottom of the screen, I have a comment here on weathering. So one of the things that happens if death does not occur for many people in our Black communities due to what I'm gonna call medical racist malpractices, the thing that occurs is what we call weathering. Now, weathering was described by Geronimus some years ago, as you can see, but it's definitely still true. Weathering means there's a stress that results from coping with a lifetime of chronic racism, if you will. The microaggressions, the mistreatment, the macroaggressions that occur actually cause a decrease in one's immune system and makes them more prone to chronic disease. This is very important as we have this discussion, because even the idea of medical mistrust, if a member of our Black community goes into the doctor and they don't feel like they're heard, they're not listened to, their pain, as Dr. McElderry pointed out, is not perceived, over time, this causes a type of weathering, if you will, that makes one even more susceptible to further chronic disease, to other disease states, can even be more susceptible to cancer. We know, according to the literature, this can also occur through accelerated aging. A person's age on the inside becomes much greater than what they actually are according to their birth certificate. So this also should be addressed, and it's something that's also caused by a lifetime of experiences of medical mistrust and discrimination within the healthcare system. Sterilization of Indigenous women living on reservations is still very recent. Thank you, Dr. Harden. And to that end, also very recently in North Carolina, there were sterilizations of Black women that was very well documented up until I think even barely 5 years ago. So thank you for bringing that up. So all of these are sources of medical mistrust and a result as well. There we go. So we've talked a lot about chronic disease. As I said, I never discuss health disparities without talking about the what, the why, the true root causes, and what we're dealing with in terms of coming to inequity. But we wanted to talk a little bit about chronic disease, and then we also wanted to talk about the status of vaccine uptake. Now, regardless of your persuasion or your feelings about vaccines, according to our public health literature, according to our history, vaccines really are some of the most effective interventions in public health. They have been successful at basically eradicating diseases, and I use eradicating gently because we do see some diseases coming back through in different communities, but we can think of things like polio. Some of us who are of a certain age still have the dot on our shoulder from receiving our polio vaccines. And thanks to that vaccine, we did not see polio cripple people as prior generations had seen. So it is an effective public health intervention. We talked about chronic disease. Now, in bullet point number 2 that I have here, the reason why we would say people with chronic disease are more likely to have negative outcomes for flu or COVID-19, which means they'd be more likely to go to the hospital or die, is because these different chronic diseases cause one to have a lowered immune system. The body is not operating at its highest immune response, and because of that, one will be more susceptible to the flu or to COVID-19. As I mentioned earlier, many of us in our Black communities are more likely to deal with some of these diseases. Some of that's genetics, some of that is the term weathering that I just introduced to you, and therefore we're more susceptible. But a highlight of this for Black communities and also other communities is that we are actually more likely to receive the vaccine when it is recommended by our patient providers. Now, when we look into the literature, if you were a Google scholar right now, almost all of the literature would tell you this, that people are more likely to get a vaccine if their doctor specifically recommends it. But let's go back to what I mentioned a few slides ago. Black patients report that the information that is shared with them is often not the same that's shared with their white counterparts. meaning some of our members of the Black community that have these chronic diseases are not being, their doctors are not necessarily recommending that they get the flu vaccine or even the COVID vaccine. They may be assuming that one will not get it anyway. Also, some studies reveal that when it comes to the flu vaccine being available in the physician office, it is a very good foretelling of people receiving the flu vaccine. It is noted that, again, among some physicians, the flu vaccine may actually be more accessible within the office than others, that some physicians may not even bother to buy the vaccine for that season. So all of these things impact access and the status of vaccine uptake among Black communities. Are there any questions or comments at this time? Okay, let's look at the numbers. I am a public health practitioner, so let's see what's happening. So what is happening? So our most recent stats here, and again, we're sharing and discussing the context behind numbers today. I really want to make that very clear. So if you look at this, one of the concerns for many years has been the difference between flu vaccine rates with Black populations compared to other populations. As you can see here from 2019, then 2020 to 2021, there was a slight decrease in the flu vaccine uptake among African Americans. But then there was also a slight decrease for a couple of other populations. We have American Indian, Native adults, there was a slight decrease. So we can see that. Would someone talk to me from the live audience or from the Zoom about why they may think that has happened? Even though that's just 1 year. I know we're not looking at some long range stats here. Availability. So one of the things I want to point out, and you could say this is slightly anecdotal, but not really. The research is showing us that between 2019 and now, a lot of people were not going to their physicians for general preventive care checkups. Now, if this is the place where the doctors are recommending the vaccine or the vaccine is available, then it would be logical to assume they would be less likely to get the vaccine. As a matter of fact, now in public health, we have a big push for people living with chronic disease to go to their doctors and get the annual visits that they need, because some have been scared to even go to the doctor during this pandemic for fear of contracting COVID-19. So that could be one of the reasons. Anyone else have anything to share? And I still want this to be interactive, so anything else to share around this slide? I also want to know, even though it's not here, we do know that these disparities, I need to point this out, when it comes to Black communities and some of the other groups, it's actually narrowed over the years. If I were to show you something longitudinal, this is only showing you 2 years. So actually rates of the flu vaccine has slightly increased over time for African Americans and those in Black communities. I want to point out, I can't help but do this because my PhD is actually in community health education. The flu vaccine does not give you the flu. I do not have stock in a pharmaceutical company, so I'm not trying to get you to go and get any vaccine, but I just want to point that out, that the vaccine is made from the dead virus. It's harvested in eggs. So those who are allergic to eggs obviously can't really get the traditional flu vaccine the way that it's made, but it is not giving one the live virus. What about the mist? The mist is giving one a weakened version of what they call an attenuated virus, which is not supposed to make you sick.
It made me sick.
We have an audience member that said it made them sick. But this
may have been my pre-existing health condition.
And audience member Dr. Dotson, I will point out, is that okay?
That's cool.
Okay. Dr. Dotson pointed out that it may have been because of underlying conditions.
Well, I will say my physician was alarmed that the nurse gave it to me.
And her physician was alarmed that the nurse gave it to her in the first place. Would not have been the physician recommendation, which sounds like Dr. Dotson has a great doctor, actually. So, but I had to put that PSA in terms of talking about the vaccine. But what Dr. Dotson shared with us, again, is very important. She just said, well, it made me sick. So one of the things in the Black community, again, going back to medical mistrust, is we have to start to facilitate better communication between our doctors and physicians, so that if I say something made me sick, or if I say I'm in pain, that you hear me and we respect that and adhere to that. So we have to also talk here about the COVID-19 vaccine uptake, of course. Now, one of the terms that you may have heard consistently when we have talked about the COVID-19 vaccine among public health professionals is this idea of vaccine hesitancy. Quite frankly, that term is making me really tired and I don't like it. The term that one of the more, I don't have her name right now, but I want to give her credit. One of our prolific Black female public health scholars has coined is the term vaccine inquisitiveness and not hesitancy. And it's not my phrase, it's hers. And the reason why that term is being used, and I'll show you that in this graphic if you can see it now, is because before the COVID-19 vaccine even came, because there were flu vaccine disparities, there was a large assumption in the literature, and many people published, that African Americans and Black people would be hesitant to get the vaccine, and we needed to go ahead and vamp up education. Now, while that may have been true initially when we were looking at the COVID-19 vaccine, if you will look at this most recent study through the Journal for the American Medical Association, the actual vaccine intention uptake of Black Americans is now, as of, excuse me, I have to move the chat so I can read this. As of June 2021, actually was higher than that of white Americans. So the reason why we want to use this term vaccine inquisitiveness is because we understand now, as we actually do the research, that many Black Americans, because of the picture I showed you of my dad and my aunt, and many of you who have been affected in your own families, regardless of race and ethnicity, many people through education and experience have actually chosen to get the vaccine. This is important as well when we talk about myths around Black health and assumptions that are made. In reality, at this present time, and I just pulled the stat this morning, the rate of vaccination in Tennessee, of course, of COVID-19 vaccination is lower than the national average. But when we look at the state of Tennessee, some of the most recent stats indicate that the rate of COVID-19 vaccination is actually 48%, and the rate of COVID-19 vaccination, meaning one dose for Black Americans in Tennessee, is actually 44%. That's only a 4% difference. That is nowhere close to the level of hesitancy that was predicted at the beginning of the vaccine rollout. So I wanted to point that out to you today as well in terms of the COVID-19 vaccine. And I will mention a little bit later, there have been a lot of great educational efforts within our communities that have contributed to that, again, along with the experiences, the unfortunate experiences and grief of COVID-19 within our communities. Are there any comments or questions around that slide? Yes, and actually for the entire state, last time I looked, our whole state was only at around 50% of people who had gotten one dose of the COVID vaccine. So yes, it's low. It is, it's quite low. It is. Any other questions or comments? Okay, I'm gonna try to click here. Okay. So I never like to discuss these disparities or differences without talking about what is actually happening. So we're gonna end and still provide some time for Q&A by talking about some public health civic movements that you may or may not be aware of. And so we started out with slavery when we talked about medical mistrust. And so we're still gonna talk a little bit about some historical things here. Back in the 1900s, things were, believe it or not, happening with Black health. There were Black women's clubs that started to fundraise and fund Black hospitals during this time to train nurses. As you would know, the hospitals were segregated for a very long time. So it was important to these communities that appropriate care was provided to our Black communities. There was a group, we talked about the Tuskegee experiment. Parallel to that, there was the Tuskegee Club of Alabama. group of people who were working on grassroots healthcare during that time. So there were some great things happening during this time period as well. And a lot of it was propelled by Black women. In 1940, we had the Office of Negro Health Work that started. This was funded by Black activists. This occurred as part of President Roosevelt's New Deal. And this was a way that money could be funded, that communities could be funded in terms of healthcare and healthcare centers. The arguments by the activists was that because we lived within systematic racism, there should also be a responsibility for the health of Black community during this time, and these offices were established. Many people associate the civil rights movement in 1960 with Rosa Parks, Martin Luther King. All of those things were occurring, and many, many other unnamed people. But what was also occurring was a movement toward equitable health. And many people don't recognize that Martin Luther King also promoted equitable health. And even when he was in Memphis, he was promoting insurance actually for the sanitation workers there. And so we don't want to dismiss that. We don't want to dismiss the role of segregated hospitals in providing care that could be equitable as possible during that time period. Last but not least, the Office of Minority Health, which there is one here in Tennessee. Ms. Charlotte Woods is actually the director now for the Office of Minority Health here in Tennessee, and I've done some work with them. It was established nationally in 1985. If you get some time, look up their web page. There are recent statistics on all racial minority groups, many programs, updates on policy, and also grant funding opportunities through this national organization and through the state Office of Minority Health Organizations. I will be finishing up shortly here. Next, we want to look at public health movements, what's happening now. Some of you may not think of Black Lives Matter and public health together, but actually it does. The attention that was given through Black Lives Matter, through the violence that occurred at the hands of some police officers, also brought the attention to racism as a public health issue. Now, let's be careful and recognize that race is a construct, meaning it was created to oppress a specific group of people. We do know that we're all the human race, but we have to deal with this construct that was created that permeates our society at this time. And so when we look at this idea of systemic racism, and I kind of want to read this to you, we're talking about public policies, institutional policies, cultural representation, and other norms that work to perpetuate racial inequality. Hence, you see the woman here with the sign saying that racism is a public health crisis. So indirectly, Black Lives Matter and everything that came along with it actually brought attention to racism, and it also being identified as a public health issue. The Black Women's Health Imperative, which I believe their headquarters is or was in Atlanta, this group works to prevent HIV. They do initiatives around college health, diabetes prevention, and they also encourage everyone to vote on positive public policy. This is just a few examples, you all, of public health civic movements at this time. Council on Black Health, I know the executive director of this organization, Dr. Militia Witt Glover. This council operates to merge research and action within the communities to take steps to empower, I will say engage Black communities in promoting positive health outcomes. They also have a website. They also work to combat social and economic inequities that contribute to health disparities. So there's a lot of movement. I'm a member of the Tennessee Health Disparities Task Force, and there's a lot of positive movement that's happening with that task force. One of the things that's happening is we in the state, across the nation, are starting to use what we call public home places. And public home place is a word that I actually pulled from the feminist literature. And what we mean by that is there are places that Black communities consider as home, as safe. They're places of interaction. They are spaces where all types of education occurs. These are sometimes beauty shops, barber shops. Sometimes they are faith-based organizations, whatever faith that is, right? It could be Islam. It could be some other denomination. It could be a civic organization meeting. It could be a community center. But these are places that we want to engage people in terms of health promotion and health education. So you see the picture here, Miss Monique Anthony, who is the Deputy Director for the Office of Minority Health in Tennessee. She is pictured here along with some other leaders. You see the church there. So what happened in Tennessee is that people within the Health Disparities Task Force and some of these leaders started to provide transportation support to people to go and get the COVID-19 vaccine if they didn't have a car. Matter of fact, Miss Elizabeth Hart, who is pictured here, is the communications coordinator for the task force. She emailed me and said, hey, do people at your church need a ride to go and get the COVID-19 vaccine? These are some of the things that were happening here in Tennessee and within our communities. Vaccine clinics occurred in faith-based organizations and in home places, because I learned from my dissertation, there are people who also mistrust health departments, going back to that mistrust of the government. Testing sites also were set up in public home places. It's important to note when the COVID-19 vaccine rolled out and people were still talking about hesitancy, there were people in Memphis, Black people, who stood in line for at least 5 hours just waiting to get the vaccine. That was an access issue. That was a logistical issue, actually, correct? But it is an access issue as well. A lot of those things have been amended and cleared up, a lot of them. Town hall meetings occurred in Tennessee and many other places, virtually, right? To stay safe, to educate people. They featured congressmen, they featured Black physicians, they featured people from home places, such as faith-based organizations, who would be trusted. And through this education, I would say an awareness and the care and belief in our own Black communities to be resilient and care for our own health, I think is why you saw some of the numbers increase in terms of COVID-19 vaccine uptake. But these are some of the things that I want to share that are happening in our state. These are a few of my conclusions. There are many conclusions. There's a lot of work left for all of us to do because we all are a community, regardless of our race and ethnicity. But my duty today was to share with you the state of Black health and what's going on and how we can all contribute to moving toward health equity. So we need more equitable interventions, intergenerational trauma, which, by the way, is mentioned when I worked on in Indian country, when I worked with American Indians in Idaho on reservations. You could not go to a meeting without them opening the meeting and discussing with you the effects of intergenerational trauma. We have to become comfortable with Black Americans being able to share the same story when necessary, and that our stories are heard, and that they are considered and respected when it comes to medical care. So last thing, it's all our responsibility. I have this quote by Maya Angelou, because still I rise, because we do rise and we keep rising. So thank you all so much for this opportunity, Dr. McElderry, the social work department, all of my colleagues, and that's all I have.
May I say something, Dr. Eldry? I just would like to say that I have been blown away with all of the lecture series that we've had, but today I did not know what to expect, but you are my new hero now. I did not expect to cry during a lecture series, but you put a face on something and moved me, and I was not expecting that. You made something very real. It wasn't a bunch of boring stats and slides. Thank you.
Thank you all.
Your presentation was absolutely amazing. And thank you for your service, for the work that you do, for making it very real. You've opened up my eyes to something that I never knew. I took more notes than I thought I would, and things that I want to research, because I'm like, that can't possibly be true, which I know it is. I'm just saying, oh my gosh. Thank you.
Thank you all.
Thank you for being
You're
so
welcome.
inspiring. Again, you're my new hero. Thank
And
you.
you all are my heroes. I think I'm a social worker secretly. Thank you all so much. Any comments, or questions in the chat? I want to honor everyone's time. It's 12:55, so.
You are glad you did it.
Okay. Closing remarks. The chair of social work may have some closing remarks, even though we only have 5 minutes. Dr. McElderry.
Dr. Story, you have really blessed us today with your presentation. It was heartfelt, it was informative, and we really, really want to thank you. You always answer the call when I call upon you, and I want you to know how much you appreciate it. And this was a presentation that was so powerful. It leaves us with, what do we do next? What can I contribute, and how can I make this better? So thank you for your inspiration today.
Thank you all for inspiring me. This is why I love being at MTSU, even having the opportunity to do something like this. So without further ado, happy Black History Month, and you all know where to find me. Thank you.